Chapter 3, Lifting and Moving Patients. So a lot of this chapter material will be covered in the classroom itself. Most of it is hands-on learning. But just to go through some basic terminology and a few considerations, we'll breeze through this pretty quickly. Body mechanics are extremely important whenever we're doing any type of movement in EMS. Back injuries are one of the leading causes of injuries that puts us off the job. And a lot of it because when we try to lift our patients, they're always in awkward positions, and there's a good chance that we're going to be dealing with patients that are pretty heavy from time to time. So it's important that we understand our own personal limitations and also understand ways in which we can utilize leverage and physics to safely move our patients, protecting both them and ourselves. So when we are preparing to lift, we want to look at a handful of factors. Our own personal physical ability, the physical abilities of our partner or crew members, the size of the patient, and things like where we have to move them to, moving upstairs, downstairs, around tight corners, those types of things. What we need to be cognizant of, more so than anything else, is going to be our own personal limitation. There's absolutely nothing wrong with requesting help. And at the end of the day, the patient created the situation, not you. If you're unable to safely move that patient without risking injury to yourself or to the patient, then you need to wait. Obviously, as with anything that we do, we are going to take additional risks when there are additional benefits that can be derived. Meaning, if somebody is inside of a car and that car is about to fall off of a cliff, we're probably going to take some extraordinary measures to try to pull the patient out of the vehicle before the car would fall. The same would apply with a vehicle fire or anything else. However, if somebody simply calls for a lift assist and they weigh in at 400 pounds, let's say, two people are not going to safely lift that patient back to their feet. We need to take the time to request additional resources, request additional crews, and get the number of people that are required to safely lift the patient. So again, looking at the object that we're lifting, our own limitations, the limitations of our crew, and then where we're actually going to be moving the patient to. Communication is also listed on there, which is of extreme importance. And it's stuff as simple as saying, okay, we're going to lift on 3. Well, does that mean that we're going to go 1, 2, 3, lift? Or does that mean it's going to be 1, 2, and then lift on 3? And clarifying that's going to be really important, because if one person thinks that on 3 we lift, and the other person thinks it's going to be 1, 2, 3, and then lift, if we're not synced up and one person tries to lift all of the weight on their own preemptively, again, we're going to have the risk for injury. So when we are lifting, we are going to be using our legs to do the majority of the lifting. We should be utilizing our arms as little as possible, keeping our back in a straight position, everything in neutral alignment. Now, this isn't an ideal situation. What I can promise you is that you are going to be presented with countless opportunities or countless situations rather, where you cannot use this ideal lifting technique, and we're going to have to adapt and overcome. So this is a great image, shows that we are bending at the knees, we're squatting down. As we lift, we're lifting with our legs, we're keeping the weight close to our body. That's, again, this is ideal. Unfortunately, we're never in these situations. What we're looking at here is, as people are moving this patient down the stairs, or up the stairs for that matter, we need to use spotters. So the gentleman who is holding on to the foot of the chair there and carrying the patient backwards down the stairs is unable to see where the bottom step is at. So the person at the very bottom is acting as a spotter, communicating to the other 2 rescuers, okay, you've got 4 steps left, 3 steps left, 2 steps left, you're on the ground. And if you've ever taken a step where either a step didn't, let's say you're walking down the stairs, you're carrying a laundry basket, you can't really see where you're walking, you think there's another step, you go to lunge forward, when in fact you're already on the landing. It's easy to jam up your knee, or worse yet, if you don't think that there's a step and you think you're on level ground and then all of a sudden there is that surprise, there's the potential for fall. In this situation, we're going to risk injury not only to the rescuers, but also to the patient themselves. Does a nice job illustrating here that straight up and down neutral alignment in the picture on the left. That's how we should be working. Again, with the weight in close to our body, lifting with our legs, keeping our back straight. We're always going to use that underhand power grip 100% of the time. I can't think of a situation where you should be trying to use some type of overhand grip. That's where you have the most strength, and it allows you to utilize your arms in a way that won't strain your back. A lot of times what we're going to have to do is reach over to pick a patient up. Notoriously, patients end up falling between the tub and the shower while naked and wet. Don't ask me why. Talk to any paramedic and they'll tell you that's how the patients always seem to fall. So what that means is that they're wedged in, they're slippery, we have nothing to grab a hold of, and it really, really complicates things. In those situations, body mechanics just, they're not possible. We have to think creatively. Sometimes we're going to wrap a strap around the patient. Other times maybe we try to finagle a sheet or a blanket underneath them to try to help lift them up. Sometimes we have to roll them. It just depends on the situation. When we are reaching, though, we want to keep our back in a locked position. Again, keeping the back straight and in a neutral alignment is going to be really important there. And then it says here, avoid reaching more than 20 inches in front of the body. Again, it depends on the situation. When we have to move our patient, we have to move them. We always want to push rather than pull. It's better on the body. Sometimes we may have to pull no matter what. I think we covered the rest of that stuff already. So let's talk about a couple situations that will dictate how we move our patients. Anytime there's a hazard to the scene that presents a risk to either ourselves or our patients, we're going to want to perform an emergency move. When doing so, although we're not going to be hasty about it, we're not going to be able to take the time to take all the necessary precautions we normally would. Probably not going to have time to put a patient on a backboard. Probably wouldn't have time to put them on a C-collar if necessary. This is an immediate life threat, meaning that a patient is trapped in a vehicle that is currently on fire. Meaning that, if you're a firefighter EMT, you're inside of a building that is currently on fire, you have to rapidly evacuate them. Somebody is laying in the middle of the roadway with traffic all around and you can't stop traffic. Whatever the scenario may be, there's an immediate life threat to either you or the patient, and we're going to have to quickly move the patients into a safe area for us to continue to work. So I think it goes without saying that in this situation, we should probably try to do an emergency move, right? If somebody was still trapped inside the vehicle or under the vehicle for that matter, we're going to quickly move them without taking much in the way of spinal precautions. Emergency moves can be done however you need to do them. In this case here, you'll see somebody grabbing the collar of somebody's shirt and just dragging them around. You can grab their feet, you can grab their arms, you grab whatever part of them you need to grab in order to get them to move in the direction you want to go. This is a good example showing that we're dragging somebody downstairs. Even if the patient's unconscious, all we have to do is grab the upper torso. We literally drag them down the stairs, and if their feet bounce off the stairs, no big deal. Now, I would hope that common sense tells you right now that we should do it, allowing their feet to bounce, not dragging their feet, allowing their head to bounce. If there's any confusion in that, I would recommend that you talk to your instructor. And then we have this, the firefighter's drag. I can promise you that in all the time that I've been doing this, I have never, ever once performed this move. It looks incredibly awkward, and I just don't really see the benefit. However, I suppose that if you ever did have to use this move, you should always introduce yourself first by saying, "Sir, trust me, I'm a professional." Here, this is actually pretty popular. All the time that I spent working with the SWAT team, we talked about how can we quickly move somebody into an area of cover. And while grabbing their wrists and dragging them or grabbing the straps on their vest may have been good options, this was always one of the best. Throw them onto a blanket, a sheet, a tarp, whatever you got, and just start dragging them. This is a very effective emergency move. If somebody is conscious and they're somewhat ambulatory, we can always just throw an arm over our shoulder, help support some of their weight, and assist them out of the danger zone. Same thing goes with the 2 rescuer move if necessary. Now, from an emergency move, we transition into an urgent move. Urgent moves are going to be something where the patient has a risk of deteriorating. So this is a time-sensitive move. However, there is no immediate life threat, so we are going to take the time to take some basic precautions. So utilizing the picture here, you'll see that there's an impalement in the stomach. Rather than just simply yanking this person out of the vehicle and potentially causing additional trauma, in this situation, the injuries are most certainly life-threatening. However, we're going to take the time to stabilize that impaled object and try to carefully remove the patient. So again, emergency move, immediate life threat, we're just going to yank them and go. An urgent move, such as in this picture here, is a time-sensitive issue. We have the risk of the patient deteriorating in the future, but we're still going to take some basic precautions to avoid additional injury. From time to time, and a great example of an urgent move here, I got dispatched for a pedestrian versus vehicle one time in the middle of the night. When we rolled up on scene, and there was a young man laying in the middle of the roadway, unconscious, in a giant puddle of blood. From the windshield survey, they call this, I was able to look out and say, hey, this guy's going to need a lot more than what we're going to be able to provide to him. He's going to need blood. He's going to need a surgeon. This is a load and go situation. So we got out there. We did a super fast, hasty assessment. Carefully log rolled him onto the backboard, got him in the back of the ambulance, and the remainder of our treatment was done in the back of a moving ambulance. The reason that was urgent is because we identified that this was going to be a patient that required a life-threatening treatment pretty quickly, but we still took appropriate precautions by log rolling the patient, holding a neutral C-spine, putting him onto a backboard, and doing some basic immobilization. All of that only took probably 30 to 45 seconds. Okay, good there. Rapid extrication. Same thing if somebody's pinned in a vehicle. If we can quickly get a collar on them, or at a bare minimum, manually hold C-spine, that would be appropriate when pulling them out of the car itself. Non-urgent moves is going to encompass everything else. If the patient's stable, if there's no immediate life threat, if we're able to take our time to perform assessments, those types of things, those are going to be our non-urgent moves. So for instance, we get dispatched for somebody complaining of chest pain. We arrive on scene, they're sitting in a chair, they look a little pale, but they're awake, they're talking to us, complaining of this chest pain. We may take the time to do a quick assessment, maybe obtain an EKG, and then from there we'll carefully assist them over onto the cot, and we'll take them out to the ambulance and go. That would be an example of a non-urgent move. In the same situation though, if we walk in, the patient's pale, semi-conscious, fading in and out, barely has a palpable pulse, this is a time-sensitive patient, clearly, so we're going to quickly throw them on the cot, get them out to the ambulance, and get going. We're not going to take time on scene to perform assessments or anything else. We have a whole bunch of different types of patient carrying devices. We got some pictures coming up here in a minute. So this is our basic stretcher. In this case here, they have both manual and battery operated ones. What we see here is a manual one. Battery operated ones actually have lifts, so that all you do is slide it in, you lock it onto the lift on the ambulance, you push a button, it automatically draws the legs of the cot all the way up, it automatically lifts the cot, and it pulls the cot into the ambulance. These things are great, truly back savers for the providers. So in this case here, this is a striker cot. You'll see striker is typically yellow and all the stuff that they do. You'll see the name printed there. Furno is red. This one here looks like, I don't know, INX or something like that, which is just one of their models for Furno. We'll be dealing with striker cots in the classroom, and then we also have a Furno stair chair. In this case here, it's specialized ambulance with equipment. This is a bariatric stretcher. It allows them to put heavier patients on the stretcher, meant for the heavier weight loads, and then they also have the ramps. And typically there's a winch in here. It's actually a winch that has a wire attached to it, and it helps pull the patient up into the ambulance. Stair chairs are great, really, really useful for taking patients down the stairs, but they can also be used to take patients upstairs when necessary. Anytime a patient is awake, they're conscious, we're probably going to want to utilize a stair chair over a backboard. The patients are more comfortable on the stair chairs. They don't feel like they're proned out and that they are susceptible to falling or anything else. It's also easier for us to use the stair chairs when turning tight corners as opposed to a long spine board. Also different lengths of spine boards, short and long. Most places only carry long boards. However, from time to time you may see a short board that could be used for basic immobilization or especially for pulling a patient out of a vehicle. Picture of a stair chair here. All the cot operations, all the stair chair operations, all these moving techniques that we talk about are all going to be practiced extensively in the classroom. One thing that I promise you is that use of the stair chair and the cot, for whatever reason, is a foreign concept to many students. It does not just come naturally. You have to do repetition in order to develop the muscle memory and the ease of use for these devices. So I expect you to show up early to class every day. Pull the cot out, take it up, take it down, play with it, do everything that you need to do to become very, very familiar with the equipment. Picture of a short spine board. There's some long boards, should cover the entire patient's body that way. Bunch of other different types of stretchers. This is called a KED device. Kendrick extrication device is what it is. And what we use this for typically is if a patient is in a vehicle complaining of back or neck pain and they have some type of neurodeficit. This is a slow process. It takes several minutes to put it on. We pull them out very slowly. This is certainly a non-urgent move. However, as long as the patient is stable and we're concerned that by moving them hastily we could cause further spinal cord injury, we would take the time to put the KED device on. There's also other uses for this that we'll talk about in class, including immobilizing a hip, and we could also use it to immobilize a child if need be. This is a scoop stretcher, and you'll see at the end there's little clips here and another one here. The two halves actually separate and allows us, instead of having to log roll a patient and then slide the board underneath them, we separate this into two halves. Each half is kind of a wedge shape there. We wedge it underneath the patient, clip it back in place on either end, and we're able to lift them straight up. Here we've got a basket stretcher, also known as a Stokes basket. These are typically used for technical rescues. So if we have a high angle rescue, if we need to lift somebody out via helicopter, you see a lot of those types of rescues out in the mountainous areas or out west. More so than anything else though, if somebody, let's say we had a contractor up on a roof doing some work and they passed out from heat exhaustion, a heart attack, you name it, we would probably go up and we would strap them into here. We would utilize our technical rescue technicians to actually bring them down via some type of rope haul system. Flexible stretcher, these typically will fold up, and these are things that you may see carried on fire apparatus. Although fire apparatus obviously are not approved for transporting patients, this type of thing is easy to fold up and can allow them to at least get some basic stuff done while waiting for an ambulance to become available. A vacuum mattress, these things are pretty cool actually. So if you can get the patient log rolled onto it, it sucks the air out in all the crevices around the patient. It forms to the patient, creates a nice, I would say it's a nice ergonomic immobilization or support device there. And then because as you suck the air out, it becomes very rigid, and you can actually lift the patient up in one of these then. And you'll see here, he's either pumping the air up or drawing it out, depending on the phase that he's in. All right, if they have a spinal cord injury. So we're going to talk a lot about spinal immobilization in class. And what we do today is significantly different than what we used to do. We've really toned back the spinal immobilization requirements. What we found is that in 90% of circumstances, if somebody is going to develop a spinal cord injury, it's going to occur at the time of the incident itself, not as a result of EMS movement or anything else. So we've also found that by putting patients on these backboards, by putting them in C-collars that were actually in some cases causing additional injuries, especially with our elderly population. So now we have some pretty specific criteria on when we need to immobilize, and we'll go through that stuff in detail in class. Let's see. If they don't have any suspected injury, you can lift them however you feel is appropriate and however they feel comfortable. So in this case here, this might be an example of, let's say you have a bunch of people that are overcome by fumes, or better yet, here's an example. Years back in Woodstock, we had a cross-country high school meet at the city park. Real high humidity, real high heat, and we had cross-country runners dropping like flies. So in that situation, they were going down to the ground. They weren't necessarily falling or tripping, but they were tired. They were letting themselves down to the ground, and they were unable to walk. No risk of injury in this case, but we did need to evacuate everybody. So this would be an appropriate type of move to use for that situation. So this is the direct ground lift. And just based on all of the body mechanics and keeping the back straight and neutral alignment and everything else that I started out talking about, this does the exact opposite. I would never, under any circumstance, recommend that anybody use the direct ground lift method. So my recommendation is don't do this. But if you decide that you want to go against my recommendation, like my kids do every single day, then here you go. You would start obviously bent over, roll them up, try to get them in close to your body, then you could roll them onto a cot. I can think of about 10 better ways to do that though. Draw sheet is kind of cool. You will actually do this all the time. We'll practice it in class, and you will do this probably 100 times in your clinical environment. When the patient is typically on, in this case, it's a hospital bed going onto a stretcher, but most times it's going to be from the stretcher going to the hospital bed. Whichever bed you're transferring to should be just a couple inches lower. You can grab the sheet and you can just drag the patient on. What we typically do, though, is we'll have two people on one side, two people on another, and it just makes the transition a little bit smoother. So you'll see starting from that position to there. They just drag the entire patient over on top of the sheet that they're laying on. Anytime that we are concerned about somebody's ability to maintain their own airway, unless we need to ventilate them ourselves, we can always put them on their side. And being on their side is called the recovery position, or in this case, since this patient's on the left side, we will call it the left lateral recumbent position. We don't do positioning for shock anymore, so it used to be that we would elevate patients' feet in theory, thinking that the blood would come back toward the core of the body based on gravity. What we found is that really doesn't work. It's ineffective. Not that you're really going to hurt anybody doing it, but it's just a waste of time. So why do it? Let's see here. So here's an example going from the EMS stretcher over to the hospital bed. We've got two people on either side there, and we're going to, again, grab that sheet beneath, and we're going to move them over. Ready, and go. Isn't that great? Look at this. Little time lapse. Okay, hope you enjoyed it. You can watch this video on the My Brady Lab if you're so inclined to do so. And that is it. Chapter 3 is a pretty quick one. Again, we go over all this stuff in detail, and we practice. We'll do hours worth of hands-on practice with cot, stair chair operations, and all the other lifting stuff. If you have any questions, reach out to one of your instructors. As always, thanks for stopping and listening, and enjoy the rest of your day.